Majid from the Kingdom, also the consultant pediatrician. I have one comment for the cost. I guess you remember when we had BCV 7, we shifted to BCV 13 without any problem because it's covered by insurance and covered by the authority over here. I guess it's not an issue, I assume. No problem for that. My question is a practical one. Those who started receiving the vaccine BCV 13, like 2 months, 3 months, then we have 2, 4, and 6, then at 1 year. Now we have the introduction of the BCV 20. What is the advice, to keep the same as if we are like those who received 1 or 2 and finish it as casual, or we give an extra or changing the timing?
According to availability, if you have 20, you can start, you can shift. But this depends on your institute. If they have a previous BCV 13, they want to finish this stock and start to use the other one. But scientifically, you can start with the new one to complete first and second dose. As you show with BCV 7 to 13, you can start 1 or 2 doses and complete with the next one, the new one.
Okay, question please, the back.
First of all, thank you, Dr. Abbas. Nice presentation. I would like to ask, you told that it's available, it is approved by Saudi FDA since August 2024. So now both of them are in the market or only one? The second question, if there is eligible criteria, if I have the choice to select between BV13 and BV13 and BV20, who is the eligibility criteria or has a higher priority to give BV20 over BV13?
For the first question, it's available in National Guard, military hospitals, and some private hospitals. So if you ask me, I think the decision for introducing the vaccine is institutional. So the institute, when they introduce a second vaccine, they will tell you, you select this, or they will tell you that we need to replace the previous one with the second one. For me, I will choose the new one. But it's according to the institute. I don't imagine they have
Usually they consider the safety profile, the effectiveness, efficacy, all these decisions for shift. Simply the Webinar 20 or the conjugated vaccine is built on the platform of the B7 and then 13, so it's already actually well studied in these different aspects in regard to efficacy, effectiveness, and so whenever it's available in your institutions, it's highly recommended to start to use it.
Sometimes the easy is difficult. We said it's easy to take the decision because we know all these questions, the answer to question, but the decision to use this one or that, it's to you or if the institution they have another way to for introduction of this practice.
Thank you, both Majid and Dr. Raja. I have a comment, we have special considerations for those who had surgeries like splenectomy who are at higher risk of pneumococcal infections, as well as those who are on immunosuppressants and require both the pneumococcal vaccine 13 as well as PPSV 23 as our guidelines in GHA in the past. But I believe with the introduction of BCV 20, and I think this requires more research, this will have great benefit in terms of cost. So now I believe we're only gonna have to give BCV 20 instead of 2 doses, which also reduces the follow-up for the patient and save their time as well as save cost. But do you have any research in the literature approving the use of BCV 20 as just a standalone vaccine against pneumococcal for these special considerations? Thank you very much.
I go through all the international recommendation on this point, and it's the final conclusion that it's individualized decision for each patient, and no special recommendation. There is a need for further research to finally accept the final recommendation either to use or not to use. But nowadays for high-risk group, it's individual decision with the physician. It's open. It's no recommendation for that after introduction of PCV.
Yeah, I
But-
think it's, as mentioned, Dr. The immunocompromised cells will be different from case to case. Currently, we provide 13, and after 2 months or 1 month, it depends on the case that we are managed, we will provide the 23, and it could be every 5 years we have 23. Now, according to the Advisory Committee of Immunization Practice, they recommend to provide actually 1 dose. And this is could be related to the question regarding the cost effectiveness. So possibly, because this could be changed in the future, they recommend that 1 dose would be enough. And the reason that's usually we, the people before, we provide the 23 because it needs a vaccine to boost the system. This is the reason that we provide the conjugate, we give later the polysaccharide. Unfortunately, polysaccharide with time will, will not have a long time in comparison with the conjugate vaccine. So we need to revaccinate it after 5 years. So simply, according to the recommendation, it could be changed in the future. 1 dose could be enough for the HIV patients, renal, liver, metabolic cell, pediatric age group, whatever that they have immunocompromised, those having cochlear implant, etc. They would be deemed as this recommendation. Questions in the back, please. If no more questions, I would like to thank Dr. Rajab Al-Dadi. Thank you very much, Dr. Rajab, for your excellent presentation. And it's my pleasure to invite my, what I said, my teacher, Professor Farahat. He's a professor of public health